Hello, everyone. Thank you so much for joining here us today at Pre-Health Shadowing. We are an international led program, student-led, minority-led, and nonprofit organizations for medical advancement. Sorry. Okay. I don't know why it's not changing. Are you guys able to see the slides?
Yes, you can see the slides. We are on the first slide. Are you able to move to the next one?
Okay. Oh my God. I have no idea why it's not changing. Okay.
No worries.
Okay. We do like to accommodate for all of our students' abilities and needs, and so we do have closed captions throughout the live session today. But if you have more ideas or thoughts on how we can make it more accessible and to meet your guys' needs, please go ahead, email us at info@prehealthshadowing.com, and we would love to do so. As well, if you want to guys stay more connected and within the loop of pre-health shadowing, please go ahead and you can join our emailing list where we usually send out to you guys any updates or notifications on any new things within our pre-health shadowings. As well, we do welcome and host all students from all across the world. So please go ahead now in the chat, tell us from what country or region that you guys are here joining us today. If you are more interested in being a part of PHS, we do offer like a student volunteer roles and as well as roles within our team. You are able to go ahead and like submit forms on our website where you guys choose what roles you're interested in being part of PHS and just submit the application on the website. For leadership positions, we do offer many roles, and all of our roles are like 100% remote, so you don't have to worry about being in person or anything. It's all through your computer. You can apply today on our website. The leadership roles within PHS kind of divides within all of the departments, like the IT department, the research, the volunteering, and more so on. And when you go on the website, we do have in depth like what role in what departments are open for you guys to apply to. For our high school students, we do offer our high school training program, which is a program for you guys to get in leadership and more of healthcare educations. That's for high school students that are transiting from high school to college. Donation is something that's very important for our program to keep it ongoing and running for all of our pre-health students to keep it more accessible and free for you guys. So if you guys can scan the code and donate, that will be something very important. And if you can share it, it's even better. Please feel free throughout the program to type any of your questions or concerns in the chat. We will be having a Q&A session at the end of the presentation where you guys can ask any questions that you may have or concerns. You will be able to take a quiz like at the end for the session to get your certificate. So please go ahead, take any good notes throughout the presentations, anything that you think it will help you, something that stood out for you, or any new information that you want to look into further. So please, you're free to do that. It's very important for us to keep this presentation and shadowing experience more engaging and connecting. And so to do so that by keeping your cameras on, that's something very nice because it will keep the live sessions more lively and more connecting. And so now I will give the floor to our physician here to start off her presentation.
Thank you for joining us today, Dr. Kimberly Trotter.
Thank you so much. Well, thank you guys all for being here. I'm excited to talk with you and hopefully answer some questions. So I am going to share my screen. Okay, great. So can you guys see my screen? Just give me a thumbs up. Okay, thank you.
Yeah.
All right, so I'm Kimberly Trotter. I'm an assistant professor of medicine in the section of rheumatology at the University of Chicago in Chicago, Illinois. So I think before we get started on this part, if you guys want to just also drop in the chat, maybe what stage of your career you're in, if you're in high school or college or, post-college, just so we can know who's here, that would be great. Let's see. So master's, undergrad, gap year, high school, college. Okay. Thank you guys. Thanks everybody. So it looks like we have a wide range here, from high school through graduate school. So excellent. So I'll just start off by telling you guys a little bit about myself. So I am originally from Maryland, and growing up probably sometime, very early childhood, I decided I wanted to be a pediatrician. I seemed to always be sick. I had a lot of ear infections, sinus infections. I was the kid who was always sick. And so I decided I wanted to be a pediatrician. As I got a little bit older, I actually ended up shadowing in the radiology department at Howard University Hospital. So that was my first real experience with clinical medicine. I also, then as I got further on in high school, I ended up applying for a program through the Uniformed Services University. So that's dealing with the armed forces in the United States. And I started working in a lab there. And so I worked there, I want to say starting in my junior year of high school. I worked in a lab, I worked in a program. So I got experience with basic science research. I got experience with making presentations and doing oral presentations as well. So it was a really good experience. And then the high school I went to was a science and technology high school. And as part of the senior year of high school, you had to do some type of project. And so through that, I was actually placed at the Food and Drug Administration, the FDA, where I again worked in a basic science lab. So when I was in high school, most of my kind of background that I was exposed to was really basic sciences and not so much clinical at this point. And so through that, though, I got a lot of exposure to research. I got to see kind of just the bench where it kind of all starts, learning more about science. And for me, why I found that very interesting, and we need basic scientists, we need translational scientists. I decided that I really still wanted to go into clinical medicine where I'd be interacting more with patients. All right. So from high school, I then went on to get a bachelor in science at University of Maryland. While I was there, I actually was part of the cheerleading team, and at the time, we were the first NCAA cheerleading team. So that took up a lot of my time between, being a science degree and then being on the athletic team. But I was able to continue working in the lab at the Uniformed Services University. So I worked there all through college, all the way up until when I started medical school. And from that, again, I continued to get a lot of hands-on lab experience, poster presentations, and I even got a publication out of that. So I think if you're interested in some form of the health sciences, getting some type of research experience, then when I was in college, so I knew I wanted to really want to be a pediatrician. I really want to work more with patients. And so during one of my science classes, somebody brought up this early selection program, which was through George Washington, through George Washington School of Medicine. And so with this program, you were in your sophomore
Dr. Trotter,
year of high
you're
school.
a little
I
bit.
mean, excuse me, to take that. Am I breaking up?
Yeah, a little bit.
Oh, oh, okay. Am I back? Can you hear me?
Yeah, no, it's all good. Thank you so much.
Okay, thank you. Okay, sorry about that. Let's see. Yeah, so there's this early selection program, which I think a number of universities do have this option. At my school, it was with George Washington School of Medicine. During your sophomore year, you applied for this program, and the benefits of it were you found out really early that you were getting into medical school. You didn't have to take the MCAT, which was the medical, school acceptance exam, and you had to maintain a certain GPA. I think it was a 3.6, and you couldn't get anything less than a B in your courses. And so myself and a bunch of other people in my class actually applied for this, and we actually got selected. And so I thought, I'm set, I'm going to George Washington School of Medicine. And so just from there, so I was a bachelor in science, but I actually polled my colleagues who were in my department, and there was a wide range of majors from college. So some were biomedical engineering, we had chemistry, chemical engineering, art history, neuroscience, anthropology. So just because you're interested in medicine or science, really your major doesn't have to be that, I think is the point of this. And I think medical schools, residencies, they look for well-rounded individuals. So they're looking for people who have all types of experiences. And as long as you take the prerequisite courses, then you have as good of a chance of getting into school. So you don't have to be a science major. All right. And just a few notes about certain opportunities. So the opportunities that I got some of them were really through people I knew, through shadowing. There's the other ones were through my school, and then another one was just researching like what opportunities were available in my area. So I just went and looked to see like, okay, well, what's out there? And so in Maryland, this was the link that I found, and there's federal government jobs. And so the one that I was with was actually through the federal government's uniform services. But there's programs from anywhere from high school students all the way through, post-college in the federal government in the sciences. So the National Cancer Institute, which is NCI, the NIH, the Army, and this GEMS program. So those are available to anybody. There's also several industry opportunities. And so a lot of these pharmaceutical companies, for example, will have locations in several different states. So in Illinois, where I am now, I know there's a lot of pharmaceutical companies here. And so they do offer programs, again, ranging anywhere from high school all the way through college. And then locally, there was opportunities through some of the universities in my area. And then similarly, so I went to see, okay, well, what's out there in Chicago? And I found just through my university, they had tons of programs available from high school through college. And so, I encourage you to go out there and look to see what's in your area, to apply for these things. If you don't apply, then you definitely won't get in. And there's lots of great opportunities out there for people at all stages. And I think that these are really important when you're applying for any level. So whether it's college, you're going to medical school, you're going to graduate school, residency, et cetera, they're looking for people who've had some type of experience. So then I actually went straight through college. I went to medical school from there. And while I got into that George Washington University, I actually ended up getting my medical degree from the University of Maryland, which is also where I went to medical school. And there was a few things that went into that decision. One was the tuition. So for me, the tuition at the time of George Washington was significantly higher than in-state tuition. At that time, they were ranked maybe in the 30s overall. So now they're ranked 22 for primary care and 32 for research. They ranked a little bit higher. Located in Maryland, so I knew I wanted to stay in the area. Both are very close proximity to where my family was. Both serve an underserved, diverse patient population, which I don't know if initially I was necessarily thinking that, but from being in that type of environment and from serving that type of patient population, it was 100% the right choice for me. But there's lots of different populations to serve. And then I felt like University of Maryland really at the time, so this was in 2005, they had a strong commitment to diversity and inclusion even back then, which I felt came across through my interview process. So ultimately, I ended up taking the MCAT. I applied for University of Maryland and I got accepted. And so I went and got my medical degree there. And those were just some of the reasons why I ultimately chose there. And that in-state tuition was huge for me because I'm still paying off these loans. So something to think about. All right. So I thought we'd just talk a little bit about diversity and inclusion in medicine. And so this is what the NIH says is relevant. So in the medical community, diversity often refers to the inclusion of healthcare professionals, trainees, educators, researchers, and patients of varied race, ethnicity, gender, disability, social class, socioeconomic status, sexual orientation, gender identity, primary spoken language, and geographic region. So diversity inclusion spans a lot of different areas. But for me, even like thinking about when I started applying for college, even that was something that was important to me. So I knew I wanted to be in a diverse environment from many factors. And I grew up in a diverse environment, and that was something that I wanted to continue and where I felt like I would personally have the most support. All right, and so I just wanted to share a couple of statistics. So this is from, I want to say the American Association of Medical Colleges, but here in green, so 63.9%, this is a figure looking at percentage of full-time US medical school faculty, and this was 2018, but the numbers are quite similar here in 2024. At the time, almost 64% of medical school faculty continued to be predominantly white and male. And then underrepresented in medicine, so here in the blue are Black or African American at 3.6%, Latino or Hispanic here at 3.2%, multiple race 1.9%, Native Hawaiian or Pacific Islander 2.3%. And then the second largest was Asian. And so again, diversity to me was really important. I didn't want to go someplace where I was going to be the only person there, or I wasn't, or felt like I might not have that support. And when I went to my medical school interview at University of Maryland, I saw a lot of people, they had people in leadership positions who were women, who were people of color. And so that was something that mattered to me. And this is just their statistics now as of October 2020. So again, it's still predominantly here in the green bar white faculty, but followed by, I feel like University of Maryland still has a strong percentage of Black, Hispanic, and other mixed races. So when I added this up, it was about 15%. And in my medical school class, in fact, it was about 15% underrepresented in medicine. So these were things that were important to me. So I encourage everybody, when you're applying for college, when you're applying for grad school, when you're applying for medical school, to really think about where you're going to feel the most supported, because getting higher education and trying to go into the sciences is hard. It's a long road, and you want to be with people who are going to support you. All right. So during medical school, in addition to school, I did a number of other activities. So I was a member of the SNMA, which is the Student National Medical Association. I also served as our chapter's community service chair. And so we did a number of health fairs that we sponsored or we were involved in, and a number of other community events through this, which I helped to organize. I was part of the Pathology and Therapeutic Curriculum Committee. I was a student member, and so this is one of the sections of the second year of medical school that comprises a lot of your book learning. I also served on the admissions committee, and then the rest are kind of some of the other volunteer jobs that I held. So I was the co-chair for a community. This was a community service health fair. We held a pediatric HIV holiday party. I was part of Peds Pals and the Family Medicine Interest Group. So these were organizations for students interested in these careers. The Community Health Advocacy Team, which went out and taught young people, high schoolers, and people who are in the juvenile detention system about medical issues. And then I didn't work in a lab anymore. So again, at this point, I was like, I want to work with patients. I really want to be a clinician. And so I stopped working in the lab. And that first summer of medical school, at least at my school, we had time off that first summer. And so I was an anatomy teacher for students who are coming into medical school. And so I think the biggest thing I can tell you from this is to make sure that you're getting involved. So whatever level that you're at, make sure you're volunteering, make sure you're involved in clubs or activities that are of interest to you. All right. So after medical school, I went on to residency and fellowship, both at the University of Chicago and Chicago, Illinois. I did residency for 3 years and then rheumatology fellowship for 3 years. And I've been on the faculty at University of Chicago now since 2015. And so I'm a rheumatologist, and I'll talk more about that. But essentially, this is kind of the track: 4 years medical school, 3 years of residency, and then and required 2 years fellowship. But I did a 3rd year for research. All right. So as I mentioned before medical school, growing up, I really wanted to be a pediatrician. That was what I wanted to do. And then when I came into medical school, I started thinking, well, maybe I don't want to just see kids. And I became interested in family medicine, which sees children, they see all the way to death. And they also do some obstetrics and gynecology. So I thought, oh, that's interesting because you get to see everybody. I was also maybe interested in sports medicine. So I had an interest just from my athletic days of bones, joints. That was something that was interesting to me. And then so after your first 2 years of medical school, which is really your book learning where you're in lectures, you're in class, your 3rd year of medical school, you go on to do clinical rotations. And so my first clinical rotation happened to be in internal medicine, and I just happened to be placed in a rheumatology clinic. I had never heard of rheumatology before I started medical school. It wasn't on my radar, but I thought, wow, this is really interesting. And through all of the clinical rotations that I did during my 3rd year, I kept coming back to rheumatology. And so ultimately, I became a clinical rheumatologist. And some of the reasons why I went into rheumatology is because you are able to form long-term relationships with patients. So I have some patients that I've been seeing since my fellowship, so 15 plus years now, which is great. It's predominantly outpatient specialty. And it bridged really my love for bones and joints with other organ systems. And again, I take care of all adults, so anywhere from 18 to death. And there's lots of diversity in terms of the disease processes that we see. And there's still a lot of unknown in rheumatology, so still a lot of research and things to discover. So those were some of the reasons why I chose rheumatology. All right, so currently, so I still work at the University of Chicago. So I'm an academic rheumatologist, and I am actually the co-director of our Lupus Clinic. I'm also the associate program director for the Rheumatology Fellowship. And so what my week looks like, I do clinic 3 full days a week, Wednesday, Thursday, Friday. And then I have 1 academic day. So on Tuesdays, we have lectures pretty much all morning. And then I have 1 administrative day where I finish up all of the notes from patients. I call people back. I go over results. And then we also do the inpatient consult service, which I'm on right now. I do that anywhere from 4 to 8 weeks per year. So if somebody's admitted to the hospital and they have a concern for a rheumatology process, then they'll call us. But again, it's predominantly outpatient. I don't stay in the hospital overnight anymore. Very rarely are we called in the middle of the night, and that's something that I was looking for in a career. All right, so what exactly is a rheumatologist? So a rheumatologist can be an internal medicine doctor or a pediatrician who received further training in the diagnosis and treatment of musculoskeletal and autoimmune conditions. So these are disorders which can affect joints, muscles, bones, and other organ systems, causing pain, swelling, stiffness. So I did think about, well, could I combine medicine and pediatrics, but ultimately I had to let being a pediatrician go, and I just ended up seeing adults, but you can be a rheumatologist for either adults or kids. All right, so just briefly about the musculoskeletal system. So these include muscles, ligaments, tendons, and connective tissue. So this is just a brief picture about the muscular and skeletal system here. There's also muscles in many of our organs. So for example, the heart has muscle cells. And then other organs, so this is, you know, in your spleen and your gut, they also have muscles. So the whole body involves muscles. And the main functions are for movement, support, protection. They help to generate heat and then also help to circulate blood. So very important system of our body. So that's one part of being a rheumatologist. The other part is the immune system. So the immune system is our body's natural defense against things that are foreign. So these include bacteria, viruses, parasites, cancers, anything that is not supposed to be inside of us. And it's made up of a complex web of cells and organs. And this picture here just shows some of the immune system organs. So includes things like your tonsils, the lymph nodes, and lymphatic vessels. There's an organ here in your chest called the thymus, your bone marrow, which helps to make our blood cells, and then even the appendix. So lots of organs are involved in the immune system. All right, so now rheumatologists deal with autoimmune diseases. So an autoimmune disease is when the immune system that I just mentioned actually becomes overactive and it starts to attack and damage, instead of things that are foreign, it actually starts to damage your own body's tissues. So in the immune system, we form various cells. So there's things called T cells. And there's also cells called B cells, and these are two main players in our immune system. And in autoimmune diseases, these B cells start to form these proteins or antibodies, which then start to attack tissues. And similarly, you start forming these T cells, which again also start to attack your body's own healthy tissue. And that's kind of the basic of what can lead to an autoimmune disease. All right. And so why autoimmune diseases happen, we don't know. We ultimately think that it's probably a complex web of some genetics. So there are several studies showing that genetics are involved, but we know it's not the whole story because, for example, in twin studies, one twin will get an autoimmune disease, for example, like lupus, and the other twin won't. So we know that there has to be other things that are in play. So other things that we're looking at are white blood cell issues or other issues with the immune system, certain lifestyle choices. So how does smoking, you know, cause certain autoimmune diseases? How do certain diets lead to autoimmune disease? What about, there's also probable hormonal influences. So some of our autoimmune diseases are more predominant in females. So we think there's probably some hormonal influence. And then there's also some suggestion of environmental factors. And so as our world becomes more polluted, the air quality is going down, there is some suggestion that autoimmune diseases are also on the rise. And I think one particular example I can give is that really is linked to environmental factors. So after 9/11, there was a number of firefighters who got an autoimmune disease called sarcoidosis, which affects the lungs. So again, these are all kind of things that we're thinking play into why people get autoimmune diseases. So this is a really busy slide, but it's just to show you how many different autoimmune diseases there are. And rheumatologists really deal here in systemic and musculoskeletal diseases. But there's also autoimmune diseases that predominantly involve the skin, that involve the gut and the GI tract, that involve the endocrine organs. There's also ones that predominantly involve just the blood cells and the neurologic system. There's ones that just involve your eyes, the kidney, and then there's kind of this miscellaneous group here. So autoimmune is a really, really broad term, and probably every section of medicine has some autoimmune disease that they deal with. But from my standpoint, again, rheumatologists deal with systemic autoimmune diseases. So these include things like lupus, which is my specialty. There's others called myositis and vasculitis. And then in the musculoskeletal wheelhouse, things like rheumatoid arthritis, psoriatic arthritis, and others. So this is a broad overview of things that rheumatologists see. All right, and then we also see a few non-autoimmune diseases, so something called osteoarthritis, which I'll talk a little bit more about, which is the most common type of arthritis, and then crystalline arthritis, which is a type of inflammatory arthritis, but it's not; these aren't related to the immune system, but also something that I, as a rheumatologist, see. All right. So now I thought we would get into some cases here. So these are kind of classic things that I, as a rheumatologist, see. So osteoarthritis, this is a kind of a classic case. So a 65-year-old female, she comes in with bilateral hand pain, and she tells us she sees what she thinks is swelling. The pain is worse with activity. Her hands feel really stiff, really weak. She's really having trouble opening cans, jars, buttoning, doing anything that really involves like fine motor function in her hands. So this is, I would say, a classic case that a rheumatologist might see. These are some pictures of what osteoarthritis looks like. So you get this, what she called swelling, but if you were to touch this person's joints here on the left-hand picture where my arrow is, it would actually feel hard, like a bone. And osteoarthritis in the hands, it really likes the knuckles here by the nails and then the middle knuckles. But you can see, hopefully, that the fingers look swollen, they look deformed. And similarly, this can happen in the feet. And so if you were to push on this, you would feel a bone here, and then the toes can start to kind of cock up like they're doing here. They can start overlapping. So these are kind of classic findings you might see with osteoarthritis. On x-rays, so this is a normal hand x-ray here on the right hand of my screen where my arrow is. And you should be able to see this. This is called the joint space here. So it should be a black space here, lots of open spaces everywhere. The example here on the left, this is a picture of osteoarthritis. So again, it likes the knuckle that's closest to your nail, but you can see here that space is pretty much gone. And the bone looks much different than the normal x-ray. So that's osteoarthritis in the hands. All right, so osteoarthritis, as I mentioned, is actually the most common form of arthritis, and it affects more than 32.5 million Americans alone. It leads to degradation of the cartilage or the cushion between the joints and can lead to changes in bone shape and can cause inflammation, which leads to pain, stiffness, and loss of mobility. So all things that that patient was complaining of. And when we talk about this type of arthritis, this is also the type that everybody's going to get as we get older. And it's from wear and tear and using our joints. Just because everybody gets arthritis, not everybody's going to have pain from it. And why some people get worse pain than others, we don't know. And common places for osteoarthritis include the hands, as that patient I showed you, but also the knees, the hips, and the back and the neck. And there is no cure for osteoarthritis at this time. And really, it's managed with things like pain medications. We're really big into physical therapy. So, you know, that patient mentioned they couldn't really use their hands anymore. So helping to make sure that they get back the strength in their hands, or there's certain things that they can do to help make opening bottles and jars and such easier. Sometimes we can do injections where we put a medication directly into the joint. And then kind of, if all else fails, then you can do surgery for some of these joints where you actually replace the joint with and take out the arthritis. All right, and then this is just another example of osteoarthritis, kind of classic area that people may get arthritis. So this is a normal knee here, the initial pictures. And again, you can see that space, the joint space here is nice and black and open. 4 years later, so again, this is a wear and tear arthritis. It's something that happens with time and with age. That space no longer is nice and open like it was in the initial picture. And then 7 years down the line, now you can see this is your thigh bone and this is the lower leg bone. They're almost pretty much touching on this side. So you pretty much lost all of the joint space over here. So this is another kind of classic example of osteoarthritis. All right, and this is an example of the back. So this is your spine. This is a normal spine. Again, you have nice wide open black spaces here between the bones in your back. With osteoarthritis, you start forming these new bone formations here in the back. So the spaces are becoming thinner, you build up new bone or bone spurs, and all of this leads to pain, stiffness, trouble with mobility. So very, very common. All right, so that's one of the common things we see in rheumatology. The second one is something called gout or crystalline arthritis. So this happens typically later in life. So 44-year-old male, he has a history of high blood pressure and obesity. He came in with severe pain in his left first toe. So this big toe here. His ankle also looked a little bit painful and red and swollen. And if you were to touch it, even just lightly, like just lay your hand on the joint, it would probably be hot, and that he probably, kick you off of him because that's how painful gout is. So gout is also really common. It affects 3 to 9 million adults in the US alone, and it leads to sudden and very intense or severe attacks of joint pain and swelling. And it's due to high levels of uric acid. And uric acid is normally found in our bodies, but we also get it from things like food. So red meats, certain seafoods, anything with high fructose corn syrup introduces more of this into your body. Lots of risk factors that our patient had. So obesity, they're overweight, again, certain diets, having high blood pressure, other things, having kidney disease, medication, like being a male, things that put you at risk. We do have treatments and
Dr. Trotter, I'm sorry, but your voice is a little bit cutting off.
yeah, I know it just off. Can you again? Am I back?
Yeah, it's a little bit better.
Hello?
Yeah, it's all good.
Okay. Did I
Thank you.
go?
Yeah, it's fine. Thank you.
Um, okay, great. Things like or also use oral steroids. Again, we can do steroid injections where we put a medication right into the joint or something called colchicine. And then long-term, we have other. These are just some more extreme examples of gout. So if you leave it untreated, these little gout crystals or tophi will build up in the bones and they'll eat away all the bones. So it's really important to treat this. Aside from helping their symptoms, you want to prevent damage to their bones and joints long term. All right, so rheumatoid arthritis. So this is typically presents in middle age, but it even can present in children. So presents again with pain and swelling. Started about 3 months ago, is worse in the morning, improves as the day goes on. It really likes the hand joints, but it tends to like the knuckles here that are a little bit closer to the palm. All right, just some other examples, again, showing you really likes these digits. It can also cause a lot of deformity, and I'm sure you can imagine that this person probably has a lot of difficulty using their hands. So in rheumatoid arthritis, this is actually an autoimmune disease. So in this case, the immune system attacks the joints. It commonly affects hands, knees, toes, ankles. And then in some people, it actually can cause problems in other parts of the body, such as the eye, the lungs, the heart, and other vessels. Tends to affect women more so than men, and commonly develops in middle age, but again, it can develop anywhere from pediatrics all the way. I had someone in their 90s. So. And then lastly, I want to talk a little bit about lupus because that is my specialty. So I focus really on systemic lupus, which means lupus involving the whole body. So this is actually my patient. She's a 45-year-old female. She came in with low platelets and a really bad rash. And then talking to her further, we found out she was having pain everywhere. She had sores in her mouth. She'd lost her hair, and she was having severe fatigue to the point she was really having difficulty getting things done. So these are some examples of her skin. So this is something we call a butterfly rash, where you get this redness here across the cheeks like a butterfly. This is a picture of her hair loss. So really, she lost all of her hair. It's thin all over. It was the worst around the edges, but she lost pretty much all of her hair. Just some other examples. This rash really involved her entire body. She's one of the worst rash cases that I've seen. All right, and so just a note, May is actually Lupus Awareness Month. Purple is the color of lupus, and the butterfly is kind of the logo because of that butterfly rash that I just showed you. So systemic lupus erythematosus was initially named after that erosive facial lesion or the butterfly rash that apparently was reminiscent of a wolf's bite or scratches. I don't know. And then erythematosus means red. So here's another picture of the butterfly, or what we call the malar rash. So populations at highest risk are women in their reproductive years, like my patient. So 65% of people are going to be diagnosed between 16 and 55, and the female to male ratio is 9:1. So it's much more common in women. It's also more common in certain ethnicities or races. So African American or African Caribbeans have anywhere from 3 to 6 times the risk, followed by Hispanic and Native Americans, 2 to 3 times risk, and Asian populations. And Black females actually tend to be diagnosed at a younger age, so 15 to 44 compared to more middle age and white females. So certainly a lot of disparities in lupus. So this is just an example of some of the organs involved in lupus. So again, it's systemic, meaning it can involve the entire body. So it can involve the central nervous system. It can cause mouth sores, nose sores like my patient had. It can involve the heart. So this is inflammation of the heart. It can cause problems with your blood. It can cause the joint symptoms. It can cause inflammation of blood vessels, problems with your muscle, problems with the kidneys, lungs, really anything. So she had many of these organs involved, including the skin. She had the muscles, she had arthritis, she had blood issues, and she had oral and nasal, oral ulcers. So this is pretty much the malar or the butterfly rash that I showed you guys. So just some more examples here. It's a rash over the cheeks, bridge of nose, and it tends to spare the laugh lines, which are here. There's another type of lupus, which she also has. So she has 2 types of skin lupus called discoid lupus. And discoid lupus can be really disfiguring. So you can see here, it's pretty much eaten away this person's ear. And if you don't treat it aggressively, and even sometimes if you do, it leaves scarring. And this occurs in about 25% of lupus patients. Hair loss is another classic, and it can be just kind of thinning, and especially around the edges, or it can leave scars like this person here. This is an example of the oral sores, so they tend to be on the hard part or the roof of the mouth. And then this is a vascular issue with lupus where the blood vessels spasm and cause you to lose the circulation here. It's called Raynaud's syndrome. All right. Arthritis is also super common in lupus, so it occurs in greater than 90% of patients, and it's often one of the presenting symptoms. People tend to have joint symptoms, so symmetric on both sides. And big difference from rheumatoid arthritis, this tends not to cause long-lasting deformities. So even though this looks very deformed, you can actually reverse this. So this person can straighten out their fingers, they can move them back over, unlike rheumatoid arthritis where the defects are permanent. Very similar areas like the hands, the wrists, and the knees. Now, renal disease or kidney disease is one of our most feared complications, and up to 65% of our lupus patients will have kidney disease at some point, and it's a major cause of morbidity, as well as mortality or death. And this graph here just again shows you some of the disparities that we see with lupus. So this is looking at the progression to kidney failure or needing to be on dialysis. So the blue line here are Black patients, and you can see their risk for developing end-stage renal disease or needing to go on dialysis was significantly more than other racial and ethnic groups. And that was followed by Hispanic patients, Native American, and Asian patients. So the 5-year survival in 1950s was 50%, but because we have lots of treatments for this now, well, maybe I shouldn't say lots of treatments, but because we do have treatments for this now, it's currently greater than 90%, but we still have a long way to go. And some of the leading causes of mortality are heart disease. So lupus patients have significantly higher risk of having heart disease compared to their age-matched counterparts. They're also at increased risk for cancer as well as certain infections. And this is just, again, showing you disparities in lupus. So the dash line here are Black patients, ages 15 to 44, and you can see that they have the highest rate of mortality with lupus, and that's across the years from 1970s to 1990s. And similarly, Black patients at other age groups also had higher mortality compared to their white counterparts. So still a lot of disparities, a lot we need to learn and to research about why this is happening and what we can do to treat this. So treatment, there's no cure, but there are lots of treatments available, and it really depends on what organs involved. And so we want to stop inflammation, we want to prevent organ damage, and then we have to manage whatever toxicities come along with these treatments. All right, so that's it for all my cases. And just to recap, some of the tips that I learned along the way. So I think it's really important, whatever stage you're at, high school and up, you want to look at what clinical and research opportunities are available in your area. But you should also look outside of your area. So there's also national and international opportunities that you can get involved in. So I met my husband in medical school, and he actually, during undergrad, went to Brazil and did research there for a whole summer. He went to Madrid, and he went to England. So there's lots of opportunities out there. I would also recommend volunteering. So, whatever you're interested in, go out there and get involved. Higher degrees. So they're, always looking for students who have higher degrees. So you can go to a post-bac program. You can get masters in public health, masters in epidemiology, masters in statistics. There's lots of options out there. They also look at when we're looking at like residency applications, for example, people who've had meaningful life experiences, so being in the AmeriCorps or the Peace Corps, and then also looking for teaching opportunities. So that's something that's also important. So, can you be a tutor? Can you help the MCAT or the SAT or the ACT? So just tips that I've learned along the way and from being on various admissions committees. So that is it for my formal presentation. I only went over a little bit, but I'll stop sharing now and take questions.
Thank you so much for your presentations. It was very insightful. And for our students, if you guys have any questions, please go ahead, say them. You can put them in the chat and we'll read them off. Or if you want to better engage with us, you can just unmute yourself and just say any questions you might have.
May I ask a question?
Yes, please go ahead.
Dr. Trotter, I may have missed this because someone knocked on my door, but you were speaking about how pediatrics was your original goal. Have you ever thought I should have gone that route, or do you feel fulfilled where you are?
Yeah, that's a great question. I feel very fulfilled in what I'm doing. I did have a really hard time letting go of that because that was something I was like, I wanted to be a pediatrician. That was what I wanted to do. And then I found rheumatology and I was like, what is this? Like I was not, it wasn't on my radar. I didn't know what it was. I never expected it. And it just happened to be my first rotation. So I was like, whatever. Let me keep going. But I kept coming back to like, oh, I still really like that. But I couldn't let go of pediatrics. So then I was like, I'm going to do a pediatric rheumatology rotation. I'm going to do peds room. And it was really sad. And I just had a really hard time dealing with sick kids. So I realized that, maybe I just like children and maybe I didn't want to care for them clinically. Yeah, thank you for your
Thank
question.
you.
I see a hand.
Um, Hi, Dr. Trotter. Can you hear me? Yes. Hi, so this is my first time actually meeting a rheumatologist. So I wasn't actually aware of what, I knew that rheumatology, what the field was, but I didn't know in depth of exactly what the specialty covers. Something that I found interesting was your clinical schedule and also how you're able to balance. You mentioned that you were an academic rheumatologist, correct? So, in terms of your schedule, like in the field of rheumatology, do you also perform any like procedures? And what kind of procedures are covered in rheumatology? And I guess I want to know like what the schedule is like for those types of procedures.
Yeah, so I would say rheumatology is a low procedure field. So we do joint injections, is kind of the extent of the procedures that I do. Um, Kind of the most common procedures are knee injections, which we just do in clinic at bedside. It's super quick, it's maybe 5 minutes. It takes me longer to drop the medication and like put the orders in the system at this point than to do the procedure. We also do shoulder injections. I've done hand injections. I did one last week, elbow, anywhere, any joint you can essentially inject. But that's pretty much the extent of the procedures in rheumatology. There's a big push now with using ultrasound for looking at bones and joints and muscles. So I'm not certified in ultrasound, but we do have an ultrasound in our clinic, and I think that's really an exciting area. That it's not really a procedure, but a diagnostic tool. So it's probably the way of the future for rheumatology. So,
Okay.
but yeah, the
Yeah.
procedures that I do are all just office based.
Okay.
We do have a
That's really interesting.
We do have a question here in the chat. Someone asked, what are some of the treatments you guys usually use for someone who came in with like severe case of arthritis? And what kind of medications do you usually recommend?
So it kind of depends what type of arthritis they have. So um, osteoarthritis, which again is the most common arthritis, is not an immune problem. So we don't use medicines to target the immune system, really just focusing on pain control. And that's in contrast to say like rheumatoid arthritis, where the immune system's overactive and attacking the joints. So in that case, we have to put the fire out from the immune system. And the first line thing that we can do for that is to give them steroids or something like prednisone. And so has a lot of side effects, but it really, really quickly decreases inflammation. So generally within a few days, people start feeling better in terms of like pain and swelling and stiffness. But then long term, we can't keep them on it. So there's lots of other medications that we can use. And if your body rejects one, then we'll try another, and we'll keep trying, until we find the right, cocktail for that specific patient. And there's a general algorithm that we use, but a lot of it also is like patient preference. So some people are like, some of our medications are used for chemotherapy, and people are like, I don't want to take chemotherapy, right? Or some of our medications are injections or infusions where you have to come in and a nurse has to give you an IV. People are like, I don't want to do that. So, it's a lot of shared decision making, I would say.
That's so interesting. Thank you for answering the questions. We do have here, they have two questions. The first question, they said, what do Peyer's patches and appendixes do in the immune system? And they also said that for someone that they hope to be a medical school professors in the future, what do you have any suggestions or advices for them?
Yeah. So some of our immune organs, like the thymus and the appendix, we don't really need those anymore, right? So that's why like when someone gets an appendicitis, you can take out their appendix. Or, a lot of times as we get older, your thymus really should not be prominent, it shouldn't be there. So if it's there, something else is going on. So they're not really essential organs. They're for development, but not necessarily ongoing. Really it's the like your glands, so your lymph nodes where we have all through our body, your bone marrow, these B T cells, those things. And then what was the second part? You want to be a professor, medical school professor, I think.
Yeah, they asked they wanted to be a medical school professor in the future. If you have any like suggestions or advices for them, and they're now in high school right now, and they're involved a lot in like tutoring and like SAT prep stuff.
Yeah, I think that's perfect. That's a perfect place to start is get experience with teaching and with education. If you're wanting to go to medical school, so I think getting some type of clinical experience is going to be important. So, see what offices are out there, what hospitals are near you that you can, find somebody to go shadow and see what you like in terms of the medical field. And then as you go further along, um, you know, kind of thinking when you're applying for, certain steps of your career, whether it's college, maybe not so much college, but medical school. And then when you're thinking about residency, um, you probably want to be in an academic place, so a place that's associated with the university, because there's lots of different types of programs, right? There's some programs which are affiliated with major universities. There's some community-based programs. So if you're wanting to be a medical school professor as you go along, you're going to want to make sure that you're staying kind of in an academic, role.
Yes, we do have a question here, and they are more curious about like the lupus sites and stuff like that, and they're asking why are there any like understandings of why these discrepancies usually exist? Like what made them happen? Are there like any a lot of understandings of what made them to come to exist within a patient?
I'm sorry, you said leukocytes? What was the first thing? I think I misunderstood.
They're talking about like the lupus disorders and stuff like that. They're asking like why do you think these things usually happen?
Lupus disorder? Like why
Yes.
lupus happens? Yeah. So honestly, we don't know. That's a great question. And again, we think there's probably many factors. So there's definitely some genetics. So they've done genome-wide studies where they've looked at individuals with autoimmune disorders and family members, and they have found some genetics associated. But again, it's not the whole story because one twin will get it, the other one won't. And then there's some families where like you'll see mom has lupus, kids have lupus, aunt and uncle. Like there's definitely some genetics, maybe some hormonal influence. Like why are women so much more affected than men? We don't know. And then it's controversial. There's some studies suggesting like flares with birth control pills or estrogen therapy. Probably some environmental factor that we don't know. So they've looked at like certain viruses, like the virus that causes mono is like the generic name, or EBV. But really we don't know. So there's lots of research going on and trying to figure these things out.
Maya and Darnell, you guys had your hands up. You want to go ahead and just ask your questions? I don't know if Maya want to start or Darnell, which one you want to go.
Hi, thank you. This is like really enriching, and I feel like I'm a lot younger than everyone in here. I'm a ninth grader, and I felt like this was really like it was really eye-opening for me. And I don't know if you had previously talked about this because I may have missed it, but I was wondering in the end, what made you what was the final push that made you decide what field of medicine that you want to go into? Because I do want to go into medicine, but I don't know exactly in what branch or exactly what I do. But I do know that medicine is my future that I have in mind for me.
Excellent. Well, yeah, we're so happy. I'm glad you're thinking about that. And, being in ninth grade and being here shows so much initiative. And so whatever you've done to find this program and, keep researching opportunities as you go along. But I think going in with an open mind is really important. So when you start your clinical rotations, as a third year medical student, I think that's when you're really going to be immersed in the different fields of medicine and you'll get broad exposure to everything. So as a third year medical student, you do internal medicine for, I don't know, we did 3 months. I think we did surgery for maybe 2 months. We did pediatrics for 2 months. You do OBGYN for 6 to 8 weeks. So you really get exposure to all the different fields. At your stage, again, looking to see what's in the community, if you have any, idea, even if you're like, I'm not, I don't know, I'd be interested in that. Just seeing if there's someone you could shadow just to get kind of an idea of what their day looks like and what patients they're seeing. So I shadowed in radiology, and the reason why I did that was because my uncle was a radiologist cousin, he was a radiologist at Howard. So he was like, oh, they have this shadowing program, and they just happened to put me in radiology. And I was like, this is not for me. Like looking at pictures all day in the dark wasn't for me. I wanted, again, patient interaction, but that was my first like clinical exposure outside of myself going to the pediatrician. So I think just keeping an open mind and seeing what you like, taking into account lifestyle. So as I went through third year, I really felt strongly like I didn't want to be in a field where I was going to be getting called in the middle of the night regularly. I didn't want to be in procedures that were going to be all day. So some of the surgery procedures, you're there all day and you're like holding tools and, there's no break for lunch and it's like really intense. You're starting at 5 a.m. Like that, for me, lifestyle wise, that wasn't what I wanted. And I also didn't want a field where it was going to be predominantly inpatient. So I wanted something that I was going to follow patients. So I think, you don't have to decide until much, much later. So third, fourth year of medical school is when you decide really what you want, and just keeping an open mind and seeing what you like is important. So
Thank you so much. That was insightful. Thank you.
Daniela, you want to go ahead next?
Sure. Hi, Dr. Trotter. Thank you so much for taking the time to give us this talk and answering all our questions. So I guess I have two questions, if that's okay. The first one is, I am currently in the road towards PA school. So I just wanted to know, in your lupus clinic, what's the teamwork dynamic that you have there? Do you have PAs, nurses? What's the team like? And number two would be, you also mentioned that you're interested in research and health disparities. So I just wanted to know if you're doing any research on that end right now. Thank you.
yeah, great. So in my clinic, we have 3 nurses who are assigned to like certain physicians. We have we share a clinic with pulmonary, so we have a number of medical assistants who also help, and then physician team members. And so on our team, we have full-time clinicians like me. So I predominantly see patients. So I have a full-time clinical load, and then also doing education stuff. And then we have MD, PhD doctors. So they have like 1/2 day a week, and then are predominantly in their lab. And then the chair of our department is actually an MD, but does not see patients anymore. He only does his lab. So he runs a lab. Does not have a PhD though. So that's kind of the team. We do not have any advanced practice providers right now. We used to have a NP, nurse practitioner, but when she moved, so we ended up hiring another physician instead. But certainly in the hospital, we have lots of PAs, we have lots of nurse practitioners. In the rheumatology community, they have their own whole like section, the associated health professionals. So those are people who, are nurses and nurse practitioners, our PAs, our research, coordinators who are involved in helping us care for patients. So I think there's a role and room for everybody. And yeah, I mean, when we had our nurse practitioner, it was wonderful. And I was very sad for her to go. And she, I know PA school and NP school is a little bit different. But I think a lot of the training there, from what I understand, comes from like good mentorship and hands-on training. And then also the benefit is, you can kind of, so 2 of my best friends are NPs, but they've changed their area several times. So you're not kind of stuck in this one area. It's kind of fun. They can, like, one was working in the ER, then she worked in hospital medicine, and I don't even know what she does now, but there's lots of, room for everyone. So, and then you were asking about research. So I predominantly do our clinical trials now. And then I've been involved with our national organization trying to increase minority participation in clinical trials. So, as you saw, like, especially in lupus, there's a lot of health disparities, and then the treatments don't work the same. For why, we don't know. But whereas maybe a white patient with kidney lupus will respond really well to our traditional therapies, a Latino patient may not, or Black patient may not. And so we really need people to be enrolled in clinical trials, but because of many factors, right? People are scared to be in trials and they may not feel comfortable. So I've worked with our national organizations to try and increase enrollment, to provide education materials. There's also the majority of rheumatologists are in urban communities. And so there's a lot of disparities in rural communities. And so I'm part of this clinical trials group. And so the first time I went to their like we have a meeting every year, annual meeting. The first time I went to it a few years ago, they also have patients. It's great. They have medical providers, they have pharmacy, pharmaceutical and industry, and then they have patients come. And so one of the patients, they lived in Georgia, and really, again, most of the rheumatologists are in Atlanta, which is the major, urban area. She had to travel 4 hours to see a rheumatologist. So there's so many disparities. Like, how can you travel 4 hours to see a doctor? Like, and then you get there, like, how are you going to get there? First of all, if you don't have a car, there's not like public transport. And then once you get there, you spend a couple hours at the doctor, right? Like, it's not usually in and out. And then are you driving back? Do you have to get a hotel? What if you have to get these treatments? Like, there's just so much, that there's still for us to try and work out in terms of disparities in medicine and rheumatology. So.
Well, thank you.
We did have a question here from Timkia, and they've asked, what do you recommend for any patients who deal with rheumatoid arthritis in terms of lifestyle and diet?
Yeah, so that's a great question, and one that patients are also really interested in. And so for rheumatoid arthritis in particular, our national organization actually recommends the Mediterranean diet. So that has been shown to potentially be beneficial for our lupus patients, especially because a lot of them have kidney issues. We have them do like low sodium diets, so our heart healthy diets. If you look on the internet, so there's lots of inflammatory diets, autoimmune diets out there, and honestly, none of them have been proven. Diet is really hard to study though. And then also, like, there's funding issues, right? Like, you have to have money to do these things, and pharmacy is interested in medications. And so, I would say there's not a lot of funding out there for those type of studies. But I tell people, as long as it's not going to be harmful. And some supplements I do think are harmful. So some supplements I tell people, I don't know, I don't think you should do that. Outside of that, I think some of these anti-inflammatory diets, if you want to try it, it's fine. I don't know that it's going to work. But the ones that are endorsed is like Mediterranean and heart healthy.
Thank you. I know, Sanaya, you have been have your hand up, so if you want to ask your question, go ahead.
Yeah, sorry, I can't turn my camera on because it's broken on my computer. But I have some questions regarding like your work to life balance, because I know there's some specialties that are more stressful than others, require more hours, like in the hospital. And also, I wanted to know if getting into rheumatology is, if it's, sorry, if it's like harder, because I know there's some specialties that are lower percent rates to get into. So yeah.
So again, those are all things when you're choosing a specialty that you have to think about, like, what do you want your work-life balance to be? And so I feel like being an academic rheumatologist, it's pretty great. Like, I start work at 8. I wouldn't say I'm finished by 5, but I leave at 5 because I have to go home to my kids. And then I'm on call right now, but I'm here with you guys. So like, I finished at 6 yesterday. I finished earlier today. So it's like being on call for rheumatologists is they call us about questions. There's not any like room emergencies that I have to rush into. That's not like a thing with rheumatology. So we'll see them tomorrow and give recommendations, stuff like that. And so it's definitely something important to think about. That's in contrast to, like, I don't know, say orthopedic surgeries, who one of like my really good friends is an orthopedic surgeon, and he gets up to go work out at like 3 a.m. and so he can be in the OR by 5 a.m. and like he's there all day. And you know, I don't know how his work-life balance is, but so I think kind of figuring out what will work for you. And then also important to remember that training is really hard no matter what. But as you get further along in your career, things change and they can get better and you're able to make, some changes to your schedule and adjustments and stuff. So I think that's something to consider when you're thinking about your specialty. And then, oh, you were asking about what's hard to get into. So I would say it's gotten a lot more competitive. And the data shows us that although we need more rheumatologists, um, that they haven't, like, the government is what funds fellowship programs and residency programs, right? And so they have to give us money to be able to do that. And so we don't have the funds to expand our programming, even though we know we need rheumatologists. And so there's definitely going to be a workforce shortage. And the numbers of people going into rheumatology has gone up. So the percentage of people who are going unmatched in rheumatology each year is getting higher and higher. Certainly it's not as competitive, like dermatology is really, really competitive, really hard to get into. Orthopedic surgery, really hard to get into. Neurosurgery is hard to get into. So I wouldn't say it's as competitive as those, probably somewhere in the middle. Um, and um, and then other specialties that maybe aren't as competitive, like a lot of pediatric spots go unfilled every year. So there's lots of open pediatric spots. There's lots of open like family medicine spots. So there's certainly some of the more competitive spots are filled and people don't match. And then there's programs where there's still openings and where we need people to work. And why that is, I mean, some of it definitely is I would say reimbursements, right? So that matters. But I think ultimately you're gonna have a long career, right? So I think you should go into what's gonna make you happy, what's gonna make you fulfilled, down the road. So
Thank you so much for your answer.
Right.
I have a question. Oh, go ahead. You can go ahead. Go ahead.
Okay. It's me again. Hello. I had a question that relates back to lupus. You stated that we don't have a cure for that yet, but what are the rates of remission for it?
oh, that's a good question. It's really, really variable. So I think it's hard to say. So some people with lupus have really mild lupus and they can kind of get away with not even being treated. So I have some people who are like, yeah, I know my labs look like that, but I'm fine. Like, and we just kind of monitor. And then I have some people like the patient that I showed you who are really sick, and no matter what we give them chemotherapy. And their body is just like rejecting everything. So I think it's pretty variable and it really kind of varies from person to person. And a lot of times what I find is people who have lupus, they have a lot of good days and bad days. So even when they're in what we say is remission, and I think our goals at this point are what we call low disease activity. And so we have these scores that we use. There's something called the lupus low LLDS, low lupus level disease activity score or something that you can like calculate. It also takes into account medications like prednisone. So we say we want you off prednisone, but a lot of our patients, we can't get off prednisone because they just like they feel horrible when they go off of it. And so getting them down to 5 milligrams or less is really helpful. And so
And I'm sorry to interrupt. So with that, like the prednisone, that can cause secondary conditions, right? So
uh,
then how does that happen? Do you treat those secondary conditions or what happens with that?
So I would say that it's a lot of teamwork here, right? So the steroids that you're talking about, so just some of the common things, one is cataracts. So we refer people to the eye doctor. It can also cause glaucoma. So again, the eye doctor. So we work closely with our eye doctors. One of our really common medicines for lupus, you also have to have eye screening every year because it can build up in the eye. So we work pretty closely with eye doctors. Um, Steroids can also cause brittle bones or osteoporosis. And so you want to make sure that you're screening patients with a bone scan to check to see how strong their bones are. And there's certain medicines that, maybe we feel comfortable treating for osteoporosis or brittle bones, and then sometimes we'll refer them to endocrinology. There's
Thank
also,
you.
yeah, so there's lots of things. It's a teamwork. So we work with lots and lots of specialties. I would say, yeah, pretty much any specialty you think of, I feel like I work with. So.
Oh. And then this is my last one. I'm sorry to take up so much time. Um, I'm a non-traditional student, and I've been out for some time. I've been out of undergrad for some time, and it's hard, like the reentry process, especially when I ended up being a teacher, so I didn't really have healthcare experience. Do you have any suggestions or any advice to kind of help me along? Because at this point, my prereqs are expired, and it's like you don't want to go back and redo your whole undergrad, or what type of options are available for a student like me?
Yeah. So I think that they do look for non-traditional students now more and more. And so I know in my medical school class, there were people who had, so it's a minority, but there were definitely people who this was their second career. And like, it's hard once you start working.
Dr. Trotter, you're cutting off a little bit.
And
I still can't hear you.
okay. Oh, right. Okay. Hello? Can
Yeah,
you
I
hear
think
me?
it's back. Thank you.
Okay. Internet issues. Oh, I was saying I do think that, there's a place for non-traditional students, and certainly in my class, and then when I've done medical school admissions and whatnot, we look at that and we value life experiences other than that. But I think it's hard if your prereqs are expired. I'm guessing you probably just have to kind of power through and redo them, which is hard, and it's hard to find time, after work. Like, I'm sure after, if I don't know if you're still teaching, but I'm sure you don't want to come home and study. But I think if you're really interested in doing a field, career medicine, then these things are temporary and they're short term, and you can power through it. And then I think also trying to look for maybe volunteer opportunities or like shadowing opportunities. Reaching out to people who are in your area, or, looking for programs that, you know, even things that you could do maybe overnight, or on weekends or on holidays when you might have a break from your regular job to get experiences. And I think these experiences, they don't have to be super time intensive, right? Like it could be you shadow once every couple months for a few hours on a weekend, or after work or something like that. But all of that counts. Those are all things that they're looking for. And then I don't know if you're still teaching, or if you're like looking for a career change. So in our office, we have research project professionals, so a clinical research, there's roles there. There's lots of roles out there. And so I know a lot of people have used those roles to kind of get their foot back into medicine, and that offers you direct, you know, um, opportunities for shadowing, or for working in research, and for working with doctors or nurses, or whoever, whatever field you're interested in. So we've had a lot of people come through that route too.
Dr. Trotter, are those listed online, or how can I access those research project professional programs?
Yeah, so they're usually just posted online. So for ours, I think a lot of them are posted on like LinkedIn or Indeed, or those type of postings, or you can go to, like for University of Chicago, for example, we have like a job page. So if you type in like jobs, University of Chicago, then there's like filters, and it'll bring up what's available.
Thank you so much.
Okay, I would say the last question here. As a rheumatologist who is actively working to close the healthcare disparities in the field, and what are some ways you think the gaps can be closed?
Yeah. So I think, one big thing is really getting everyone involved in research. And so, we need people from all backgrounds, all races, ethnicities, sex, etc., involved in research, because we know that these medications work differently, and we know the disease process is different, and we know, that probably even the initial like genetics or maybe physiology might be different. So I do feel strongly that helping people understand research and forming trusting relationships with their care team is important, and that's one way that we can start to close the gap. And then also, again, kind of going back to trust is, one thing that we see a lot is that we'll recommend things to patients, they don't want to take them. And like, sometimes even patients who've had lupus for a really long time, I'll ask them questions and I realize like, wait, wow, you've had lupus for like 10 years, but you really don't know what it is. So kind of, what other resources are out there. So there's lots of online educational tools that we can refer our patients to. There's support groups. So there's national organizations, but there's also, organizations in your area. And then one good thing that came out of COVID is we can do things like Zoom, right? And we have a lot of virtual options now. And so just getting people engaged in their health and understanding really their disease processes, and make sure they are taking the treatments. And if they're not, like, why not? Or what concerns do they have, and trying to really work together are some of the other things we can do.
Yep, we do have around only 10 minutes left. So Vidi, if you have any questions, go ahead. I'm sorry if anybody who had any questions, a lot of them were not able to answer, but feel free to always like contact us or email us after we're able to contact you. But Vidi, if you have any questions, please go ahead.
Hi, Dr. Trotter. So I just wanted to ask you, like, what do you think was the hardest part of like going to the medical school that you would want, some of us who are pre-med students who are potentially going to medical school to like look out for?
Yeah, I think, the first 2 years of medical school are really hard, and they're kind of like college, right? They're very lecture focused. You're not seeing patients. You're like, why am I doing this? And it's a lot of studying. So I thought I studied a lot in undergrad. It like quadrupled, maybe 10 times when you're in medical school. But I think you have to keep your eye on the goal and like what's important for you long term. And that's kind of what helped me keep going. And then make sure you find your village. So, I had a group, we would study together. So we'd support each other, and we'd have fun too. So it's, we would work hard, but we also had fun. So I think the first 2 years are really hard. There's a lot of book learning and book knowledge that you have to get through, and the courses can be challenging, like the pre-med, but really just kind of keeping your eye on the long-term prize. And it gets better. Like I feel like third year, you're finally seeing patients, and you're like, okay, this is what I'm doing this for. And so you're like, okay, I can see where this is going. And then fourth year is great in medical school. It's like you're like, oh, I'm almost there. And there's a lot of opportunities for other things in fourth year, like electives. Like I did a elective in Argentina for a month. So there's lots of like other things you can do as you get farther along. And same thing like residency first year. Oh my gosh, it was so hard. Like intern year was hard. But it goes by quick. Like it really does. Like I know when you're going through these things, it really doesn't seem like it's quick. But I can't believe I've been an attending doctor for 15 years. That like blows my mind. But when you're going through it, it's hard. But everything has an end.
Right, yeah, because I did see that you have been doing like a lot of community work along with your like school. And I did try doing that when I was doing my bachelor's. I'm in my gap year currently, but like being a part of like community organizations, doing volunteer work, working, also applying, like it's just such a hectic, like gets super hectic that you're like, okay, this is like a lot. But doing this with schoolwork, I feel like that would be such a challenge. But it's also important to put yourself out there so that you can make the connections and like get in contact with everybody.
Yeah, I think you have to find a balance, right? And like not all of these things take a ton of time, right? So like some of the volunteer, like a community like health fair, it takes a lot of time up front, but it's a one-time, thing. Or some of the volunteer things we would go once a month, or and then it's a couple of hours. And so, and you also don't want to say yes to everything, right? So that's I think say yes to things that are meaningful to you and things that you like. And if you do it and you're like, oh, it's too much, or I can't do it, it's okay to say no. It's okay to pull back too, to make sure that you're taking time for yourself and doing other things so you don't get burned out.
Okay, sounds good. Thank you for your advice.
Thank you so much, everybody, for all of your questions. It was very wonderful and engaging. And thank you so much, Dr. Trotter, for answering all of the questions. It's very nice having you here. I'm just gonna go ahead and share my wrap-up slides. Okay, so it was very wonderful having everybody here. Thank you so much for sharing all of your questions. Please go ahead in the chat if you want to able to reflect. Please tell us anything, any takeaways, shout outs, or anything that you were introduced to that you want to learn up more about, or something that you really liked about the sessions from today. It will be wonderful listening to all of you guys' reflections. Okay. Also, if you want to be more recognized within PHS, you are able to go ahead and submit a blog submissions to us about any of your success stories or reviews about the sessions. It'd be wonderful to hear anybody's opinions and thoughts about it. Also, again, if you're interested in being more engaged within PHS, you are able to join us as a student volunteer or be on the team. Just go ahead on the website. You are able to fill out an application form and then check any roles that you are interested in, whether as a volunteer or within the PH departments, and then we will look into it. Again, donations are very important to keep our program going. So if you are able to donate, please go ahead and do so, because it will keep our program more accessible and free for all of the pre-health students all across the world. You are able to gain a digital certificate from today's session. You are able to now to go on the website, take a short 10-question quiz, and then you need to get at least a 70% or more to be able to get the certificate, and you are able to take it twice. When you receive the score of a 70% or higher, you right away are able to download your digital certificate. If you have any questions, you are very welcome to always email us or anything regarding that. You can always email us at info@prehealthshadowing.com. Again, if you're stepping out or you came in late or anything, we will have the sessions from today all recorded for you, and it will be uploaded on our YouTube channel at Pre-Health Shadowing. So you are always able to go check it out, and there are our previous sessions that have been recorded from before along on our YouTube channel. Please be sure to catch out on our future sessions. Make sure that you are assigned to our emailing list and on our social media platforms to be more updated with any future sessions that we will be holding on. Thank you so much for everybody for joining here us today with Pre-Health Shadowing. It's very nice having everybody. You guys have a lot of wonderful questions that we have asked, and thank you so much for our Dr. Trotter who have been here, taking off for time, and being here answering all of our questions. Thank you so much. So if you have any questions, please feel free to stick around or email us or ask if any of our students are here.
Thank you.